Thank you. Thank you very much for adjusting me. I'll be talking about a new kid on the block, and that is the enhanced monofocal, which okay. Sorry about that. So basically, when you're looking at today from a monofocal IOL perspective, I think things have changed. We had the non-foldable lenses which were there, then came in the foldable IOLs. I would say that obviously today the foldable IOL is the standard of care because your incision is small, but still in SICS people do the non-foldable. And then from the foldable IOLs, the design and the optical properties have improved. So earlier we had the spherical monofocal lenses, and I don't know why the company still makes spherical monofocal lenses. Obviously, there are very few conditions where they are required, and then came in the aspheric monofocal lenses which were there. Now, the current day monofocal lenses, as you all know, has the difficulty in patients seeing intermediate and near. That was the problem that we had. Distance vision, obviously you can get good crisp vision with the IOL biometry being pretty accurate, as also you're being able to get the toric intraocular lenses in position. Now, as we have moved on, you can see that when the requirements have changed significantly because the lifestyle has changed. So most of us would be needing to drive and then also look at the Google map to see as to where you are, or it comes on your screen. So basically you need distance, you need intermediate modular kitchens, grocery shopping, you have obviously shopping that's digital, online, on computers. Kids are not playing football and basketball and cricket nowadays, but they are doing, most of them, the grandparents as also the kids are working on the video games, etc. Entertainment has also shifted, like instead of going to the large screen, I was watching the television, the match on the phone. So things have really changed significantly from where we were and what we are, and daily activities have become a requirement, where I think majority of the requirements today, you have Kindle and things like that, so you don't actually are reading finer prints, but the intermediate vision has become something which is very important. So as we see, the new advancement that is there is called as the enhanced monofocal. This concept was introduced by the iHense lens, but today I think there are a couple of lenses which are coming in, and now the thing is to get a patient nearer to N8, N6 with maybe a little bit of micro monovision and no photopic phenomena. So that's what we are looking at, and this is the key area, that intermediate vision has now been conquered to a reasonable extent by these enhanced monofocals. So these intermediate visual acuity, which I just said, is something which is very important in the daily activities as per the active lifestyle of an individual. And the outcomes for this particular thing would therefore depend upon what is the expectation of the patients. One important and good thing that I have in the advanced monofocal, it has totally cannibalized my monofocal practice today. I don't really use any monofocal lens today. The cost difference is very slight. So if you're going in for an EDOF lens and you are asking the patient to spend 50,000 rupees more, versus in a monofocal where you're asking the patient to maybe spend 5,000-7,000 rupees more, you don't really have to talk, you don't have to do your own brain damage nor the patient's brain damage. But usse patient has come, you just I just put two categories. You want something which will give you good vision for distance, and something which is a trifocal lens. So that's what I talk to the patient, and then basically between the two they decide that's what it is. So the post-op consideration, therefore, on the patient's outcome, etc., would therefore be dependent on what were the expectations, what are the pre-operative consideration, and what is the IOL power selection that you got. So this is a lens that has been made available to us in India, I think about maybe about 6 months ago. We still don't have the toric variety, though it's available, and we expect the toric variety to come. So those who have used this Hoya lens, this is based on the Impress, which is also, they say, ozone treated, and the incidence of the PCO is less. The stability is pretty good, you can see, and it has a filter in it. So the Vivinex Impress, which is there, is an aspheric spherical abrasion correction, which is tolerant to coma. This is very important, that even if there is some slight decentration, it is tolerant to coma. It is tailored for giving you an improved intermediate vision that you have, and distance visual outcomes are absolutely more tolerant, as also the intermediate, than a standard monofocal, and I'll tell you the reason why it is. Material hydrophobic acrylic, gristling free, no calcification, C-loop 13 millimeter, full 6 millimeter optic, very low PCO, rotational stability for the toric is pretty good. The other important thing that I have seen is the multi-cert preloaded IOL. So all their IOLs today in the Vivinex and the Impress family come as a preloaded lens, and the injector multi-cert is really fantastic. You can even push it through a 1.8 millimeter, so you have a nozzle which goes forward to go through as a wound assisted, or you can go into the wound and do that at a 2.2 millimeter. Now the enhanced monofocal IOL does not compromise on the distance visual acuity, and the incidence of photopic phenomena is similar to that is seen in the patients who have a standard monofocal lens which is there. This is designed to provide maximum depth of focus without significant clinical compromise in the quality of distance vision. So let's just say as to what exactly, how does it achieve this particular thing. So if you look at the center, it is the central 2 millimeter which is there. If this is the side profile, so on the side profile there is no difference between when you are seeing a monofocal or an enhanced monofocal. Now there is, in this central 2 millimeters that you have, there are undulations. That means there is a positive and a negative. So there is a convex and a concavity, and which are very small steps, very, very small steps. It's not a ring or a circle, but what does it do? These positives and the negative will give you an elongated, so it's they call it as a monofocal EDOF or whatever it is. So you can see this is the area or the range that you have, which is achieved not by rings, which was the standard when the Symphony came in as the first EDOF, and now you have, for example, the Vivity, etc. You still have rings. In this particular case, there is an absence of ring, but it is still getting a stretch. And this stretch of it's basically the Strum's conoid that you have. So it's this stretch that you are getting by the positive and the negative that is giving you the entire thing which is there. So this is a novel aspheric design which is designed to provide wider range of function of focus. Enhanced monofocality will mitigate the impact of residual. So basically, when you have this stretch, even if there is some residual refractive error, it will either be in focus here, or it will be in focus here, or it will be in focus here. So that's the basic advantage that you have, and therefore it becomes much more tolerant to any decentration, as also it is more tolerant to any residual refractive error which is there. So this is, I told you about the peripheral region. The profile converges to that of a standard aspheric, which is the negative aspheric that has to provide good distance visual acuity. And there is no split in the light as such. So this is therefore, in case of decentration also, the reduction in contrast is lower as compared to the standard negative aspheric monofocal lens which is there. There is just a comparison between their normal Vivinex, this is the normal Vivinex, the Vivinex Impress and the Technis, and you see that the comparison, if you have as to the measuring the contrast across the whole three things between the lenses, it compares favorably. This is the injector system. It can come as a screw type or it can come as a push type, whatever you like, and it is uniquely designed. You have to just put viscoelastic. This comes in a preloaded thing. Just take out the cartridge, push it in, and it's a very smooth and a gentle insertion that is there. I have yet to break a lens or to actually puncture or whatever, or to have cracks in the lens with this injector system that is there. So this is finally what I'll just say. This is the product specification. As of now, it is available from +6 to +30 in steps of 0.5, hydrophobic, UV, blue light blocker, rough haptic surface to give you the. This is a small change that has come between even the Technis and the Technis Toric 2, was that the haptics, instead of being smooth, have been roughened. So that kind of causes stickiness into the capsular bag, and the same thing is here so that you don't get rotation. So this is, friends, goes through 1.7 wound assisted and 2.2 if you actually go in. So this is what I have to say. Early results for 6 months have been great. Most of the patients are getting N8, and if you do a slight monovision, they tend to get on to the N6 which is there. Thank you very much for your kind attention. Thank you.
Dr. Sachdev?
Yeah.
I have a question. How does it compare to the Vivity performance?
So it gives you the same without spending too much. I have really no love or liking for the EDOF. I started with the Symphony, gave it up. Vivity also, I have done a couple of them because the Vivity still has photopic phenomena. So that you guys will be able to, those who have used it can say, and it does not give you an N6. So basically the patient is spending a far more amount of money, and the patient is not getting reading vision. And I feel that with the EDOF or the Vivity as compared to a trifocal also, there isn't a significant increase or a decrease, I would say, for Vivity for the dysphotopsias. So therefore, as I told you, either I go in for my monofocal, I go in for an advanced monofocal, or I go in for a trifocal straight off. So I don't have anything in between which is there, because incidence of dysphotopsias because of the edge treatment of the steps that is there, whether it is in the Zeiss or in the Synergy, or Panoptics doesn't come still to that. I think they're coming out with a new lens. So that the dysphotopsias have gone down. I think a better lens that is available in Australia that has been released and in parts of Asia is called as the Pure C. That is the next generation of iHands. This gives a slight 0.25 more near. That means that your ad goes down to about 1.25 to 1.5 for the near vision, and that's the same that you are getting with the Pure C. Pure C is supposed to be better. So I personally like either this or the trifocal.
So just an observation, you made a comment, why are people still manufacturing spherical?
Yes.
So actually your iHands or these enhanced monofocals are actually you are reducing the central 2 millimeters, you are making them spherical.
No, you are inducing a spherical aberration, but
the whole lens is spheric, but you are inducing again spherical aberrations to increase the depth.
Agreed, but the point is that the periphery of the lens is aspheric or negative aspheric, so that is where the quality of the vision or the focusing, it's basically the peripheral area where the focus is different from the central area.
Yes.
So that's the point. So when you are looking at an aspheric lens, the aspheric lens is definitely, whether it is zero asphericity or it is negative asphericity, but making it a positive asphericity, which all these lenses are, they just price it lower. But there are very few post-laser cases where you would want to go in for a positive spherical, otherwise you don't really need it.
Yes.
So that's the thing. They are inducing, but it's only in the central 2 millimeters.
Yes.
Yeah.